Welcome to Bench to Bedside, a weekly series of live conversations about recent advances in cancer, from the research bench to treatment at the patient's bedside. And now, your host and the director of the University of Kansas Cancer Center, Dr. Roy Jensen.
Cancer can affect anyone, but it does not affect everyone equally. For example, the overall cancer death rate is 25% higher for blacks than whites. At the University of Kansas Cancer Center, our scientists look at this complex issue from many disciplines to understand and eradicate the drivers behind disparities in cancer. Hi, I'm Dr. Roy Jensen, Director of the Cancer Center. With me this morning is Dr. Ron Chen, a radiation oncologist and the Cancer Center's Associate Director for Health Equity. And joining us via Skype is Broderick Crawford, a member of our Community Advisory Board, as well as a patient research advocate. Also joining us on Skype is Megan Peters, and she is here to take your questions. So welcome, Dr. Chen. Let's start with the phrase health disparities. Could you define that for us?
Health disparities is the overall idea that some group of patients may not have the same access to care for their condition, and therefore some group of patients may have a worse outcome than other groups of patients. In cancer, for example, as you mentioned, Black patients do worse than white patients overall, higher death rates, and that relates to access. And health disparities overall is something that we're really passionate about here at the KU Cancer Center in trying to address.
So, Broderick, I want to start with you. Could you tell us about your background in terms of all of your work helping to address health disparity issues across the entire Kansas City region?
Absolutely, and thank you, Dr. Jensen and Dr. Chen, for allowing me to join you today. My experience basically goes back to initially with my dad. My dad unfortunately passed January of this year. My dad was a 14-year prostate cancer survivor. But as we were caring for my dad, I was noticing things that were troubling. There were times when he was in the hospital, times when he was meeting with his oncologist, times when he was meeting with his urologist, that were things that were shared with him that he didn't understand. Now, part of the challenge with my dad is he wasn't diagnosed until he was 77. And so at that point, the treatment and things that were available for him, it was different because of his age, or he was limited because of his age. So from that, I began to become an advocate, because I said to myself, I'm very fortunate, having worked both at KU and within the multiple health systems throughout the city. I knew who to call. I'm good friends with physicians and nurses, etc. But what happens to that patient who doesn't have that access, who doesn't have that network, who doesn't have that level of knowledge of who to call? And so from early on, I became an advocate, because I took on the mantra, no longer on my watch. No longer should it be allowed for a patient to have to make decisions that are uninformed, that don't have the various different options that are available, and to be able to seek out other opinions when it's warranted. And in many cases, particularly in the folks of color, the Latinx, the African American, and the refugee communities, whatever the doctor says, that's what they do. In my mom and dad's generation, whatever their doctor said, there was no questioning the doctor. And it wasn't that the physician was doing anything, quote unquote, right or wrong, but there was opportunities for them to get other information that physician may not have shared with them, strictly because of their color. And so we have found that there's a number of situations where individuals are not providing the best level of care, the best level of treatment, either because of what they look like or the type of insurance that they have. And so I have tried to become an advocate to sound the alarm, to blow the trumpet to say this no longer should be the case. And I'm very happy, I'm very proud of the physicians that I work with at St. Luke's because, at St. Luke's and at KU. I worked at St. Luke's in the lab. They have come right alongside with us and said, yes, this is the right way to provide care. We want to make sure that we're doing everything possible to provide the best care that's available for every patient that walks through the doors of the University of Kansas Hospital.
Well, and we're all very grateful for the role that you play in this issue, Broderick. I want to turn to Dr. Chen. As the only NCI-designated cancer center in the region, I think we have a unique role in addressing health disparities. And could you maybe try to address where you see our center in addressing these issues?
Yeah, thank you very much. So at the KU Cancer Center, we take care of patients from many states around the country. We even take care of international patients. But we have a special responsibility to take care of patients in this region. We've defined our region as our KU Cancer Center as serving the entire state of Kansas because we're the only NCI designated cancer center in the state, and also serving Western Missouri because of where we are located. And so that's our catchment area, and we want to serve and make sure cancer patients in Kansas and Western Missouri are served by our cancer center so that these patients have access to the expertise, the treatment, the clinical trials that we offer here. And so disparities relates to certain groups not having access to the expertise, to the treatments that we offer. That could be related to racial disparities. It could also be related to where somebody lives. So patients who live in rural areas that have cancer may not have or may not know how to get a second opinion, may not know how to access clinical trials. And so our cancer center, we're trying to do a lot of different efforts to try to really serve this entire region, regardless of somebody's race or where they live. And actually this weekly series, is an example of what we're doing, trying to get cancer education out to the community so that people who are diagnosed with cancer or know somebody who was diagnosed with cancer can have the latest information available.
So you mentioned the phrase catchment area, and that's actually an important new concept in the guidelines that we're under from the National Cancer Institute, and the fact that it includes all of Kansas, Western Missouri. Throughout that particular region that we serve, what would you say are some of the major disparities that exist?
There are many disparities that exist, but I'll just give a couple of examples. One example is prostate cancer, which is something that I treat. We know that in prostate cancer, Black patients are more than twice as likely to die from prostate cancer compared to white patients. There are potentially many explanations for this, but part of the reason for the higher death rate in prostate cancer is because we know there's less screening done in Black men, and we know that Black men are diagnosed at a later stage. And of course, if it's later stage, it's harder to treat and to cure. So knowing that disparity in our catchment area, part of what we're doing, what we did recently, was we actually had a free screening event in September. And part of the issue with COVID this year is also, I think COVID has really impacted people getting screening as well. So in this year, when COVID has impacted a lot of things, especially in prostate cancer where there's disparity, we decided to offer free screening in September, and we worked with community leaders like Broderick to really try to get the word out that screening is really important even this year, and to try to offer free screening so people can have access to that. So I think that's one thing we're doing to try to reduce disparities there. We also know that there's a disparity, racial disparity in breast cancer as well. For example, Black women with breast cancer are more likely to be diagnosed with something called triple-negative breast cancer, which is very aggressive. And we have experts, researchers here at KU, like Dr. Priyanka Sharma, like Dr. Shane Steckline, who specialize in treating triple-negative breast cancer, also specialize in researching how to improve the treatments. And so we know about these disparities in our catchment area, and these are some of the efforts we're doing to try to reduce those disparities.
Mm-hmm. So if you're just joining us, we're here with Dr. Ron Chen and Broderick Crawford talking about health disparities and health equity. Also, Megan Peters, who is joining us via Skype, can take your questions. And I understand that we have our first question. Megan?
We do. Our first question is, what are some of the ways that KU Cancer Center addresses cancer disparities, specifically in rural communities?
Okay.
I can start,
Yep.
and I'm sure others can chime in. I think that's a really important, because I think rural disparities is another really important issue, maybe not talked about as much as racial disparities, but certainly a really important issue, especially for us. There's a couple of things we're doing. One is trying to figure out how do rural patients have access to a second opinion, to an expertise, to sort of confirm the diagnosis and tell them about the treatment options. And so one thing that I think has really been developed this year to address that is telehealth. And so somebody may not be able to drive 3, 4, 6, 10 hours to come to Kansas City to see the experts here at KU, but with telehealth, somebody can really just call our navigators and be scheduled for a telehealth consultation for a second opinion very quickly, in a week or two, get a second opinion. So I think that's really important when rural cancer patients have access to the expertise. I think the other thing that's really important is trying to see how we can have better access to clinical trials for rural cancer patients. Clinical trials often is a way to access the latest treatment available. And so I think the KU's Methonic Cancer Alliance, which is a consortium of cancer centers throughout Kansas and Missouri, really helps patients have access to clinical trials, even if they don't live close to Kansas City.
I'm going to ask Broderick to weigh in on this too, but first I want to remind everyone to remember to share this link with people you think might benefit from our discussion. Use the hashtag bench to bedside. So Broderick, one thing we haven't talked about yet is your role as the chair of our community advisory board. So from that perspective, do you have anything to add about our efforts around the rural community?
Absolutely. And again, thank you for this opportunity. One of the things that the KU Cancer Center's Community Advisory Board wants to do is we want to share and review the community priorities and concerns. So one of the things that I advocate for is that we can't help a person if we don't understand what's happening with that person, what's happening in that community. Prior to COVID, I have had the opportunity myself to go to places like Dodge City, like Garden City, to Finney County, to Crawford County. And the purpose was to better understand what was happening on the ground. So it's one thing to be able to talk with a person, but it's another thing to actually be with that person in their environment. One of the things that I noticed, because I was one to get right in with the folks there in that community, so I got on their bus line. And what was interesting to me is when that bus line went to Walmart, when it went to Target, they announced, you have now reached Walmart, you have now reached Target. But when they went by the Genesis, which is an FQHC, and when they went by the Finney County Health Department, nothing was said. And so I simply had a conversation with the leadership there and said, what would happen if they simply, just as you announced Target, just as you announced Walmart, you also announced the Finney County Health Department and the Genesis FQHC? Guess what? Their appointments went up 30% simply by individuals being made aware of what is available in that particular county. Oftentimes, we find that there may be resources available, but folks aren't aware of it. They are not knowledgeable of it, or they have a lack of trust in going to those particular places. It rings true as we look at cancer. The same thing occurs, is that when folks hear the big C, one, it affects them mentally, and then two, when they walk into that doctor's office Are they really clearly hearing and understanding what's being shared with them? Oftentimes we hear chemo brain. Oftentimes folks are in a fog. So how do we help them navigate through the burden and the anxiety and the what they are feeling as it relates to having that particular disease, and then helping them to say there is a pathway for treatment, there is a pathway for care, there is a path for you to live through this particular disease, and being able to talk with them in a way that they can understand, not with all of the research and the medical terms, but just simply saying, we have a way through this. And the best person to do that is those that have already walked that path. So as we have advocates with Pivot, as we have individuals through the KU Cancer Center, the Community Advisory Board, we are poised to make sure that the voices of those who have walked this path will be able to share with those that are newly diagnosed.
Great point. One thing I want to talk about with Dr. Chin is that in addition to your role as chair of radiation oncology, you're also the associate director for health equity in the Cancer Center. And could you talk a little bit about why that role was created and why we feel that that's such an important position?
Yeah, and I have the responsibility to really help our cancer center serve all the cancer patients equally, to make sure that regardless of race or whether somebody lives close to far from here, urban or rural areas, that people have access to the highest quality cancer care, have access to the expertise in clinical trials. So, and I work with a group of people on this effort. I think the fact that I have this role really is symbolic of how important our cancer center thinks this issue is. And really it's a continuous effort. Part of what we do is to monitor data, cancer data from both the state of Kansas and the state of Missouri, and we look at data to see if there are disparities in different cancers by different group of patients. And that kind of data helps us figure out what priorities we can set to really have interventions to reduce disparities. We talked about disparities in prostate cancer and what we did about that. We talked about disparities in breast cancer, what we did about that. We talked about disparities in terms of increasing access to clinical trials for rural patients. So we continue to monitor data from both states to look for opportunities. And also, we work with community leaders like Broderick, like others in our community advisory board who live throughout the catchment area, really to try to implement these efforts so we can really have improve access to care for all patients in our catchment area.
So you mentioned clinical trials and what an incredibly important part of developing new and better treatments those are. But I think everyone can agree that there's been kind of has long been a lack of diversity in participants in clinical trials. And so, first of all, why is this, and what can we do to change this, and why is it so important to have broad representation in our clinical trial enrollees?
I'm happy to start, and I would love Broderick to chime in as well. I think the question of why there's a lack of diversity in clinical trials, I think there's multiple facets to this. Part of it may be access, part of it may be trust, part of it may be thinking clinical trials being experiments. But I do think that the lack of diversity in clinical trials is really an important issue, and it's increasingly being recognized as an important issue. And there's two reasons I think why this is important. One, as I said before, clinical trials often represent access to the latest treatments available for a particular cancer. And sometimes patients who enroll in clinical trials have the best outcome because of being participants of a clinical trial. So having access to clinical trials for all patients and having diversity is really important so that patients have the best outcome. The other reason why I think diversity is important is that cancer treatments may not work the same for every patient. There may be biological differences in cancer by race, for example, and if clinical trials of a new treatment shows a benefit, and if all the patients in the trial were white patients, for example, then we don't understand whether that new treatment works equally as well in Black patients or Asian patients or Hispanic patients. So then we don't have that information to really best treat every patient with that particular cancer. Something that's not often discussed is that in clinical trials, there's not only lack of diversity, but you almost never see any Asian patients on clinical trials in cancer. And I think that's really an important issue as well.
So it looks like we have another question, but first I want to give Broderick an opportunity to weigh in on that last issue.
Absolutely, and thank you again. And Dr. Chen, I think, basically stated it quite well. In some instances, or in many instances, trust is an issue. As we know, how African Americans were mistreated through the history of clinical trials and research. So that's a awareness. So understanding the value of participating in a clinical trial. So there's an awareness and education piece or component that needs to be explored. But then I will also say we also have to educate our researchers, like the two of you who when you're leading a trial, what you do is you're very intentional about making sure that the population of the individuals on that trial is diverse. Too often, researchers, if they need to have 500 people on a trial, they'll get the first 500. Well, in most cases, those are individuals who are white. Rather than saying, no, we're going to push back if we need 25% African American or 15% women, that no, I'm not going to take all 500. I'm going to make sure and be very intentional about making sure the population of this trial that I'm leading meets the standard, meets the demographics of the community that I'm serving.
Great point. Megan, what is our next question?
Yes, the question is, what strategies can be used to connect with communities during COVID-19 to ensure that all voices are heard?
Broderick, why don't we start off with you?
Absolutely. So one of the things that we're very proud of here in Wyandotte County is that we have developed a Wyandotte County Health Equity Task Force. So we have a task force that is poised and has the responsibility of making decisions for our county as to where testing occurs. So for example, we have multiple subcommittees. We have a testing subcommittee that determines where testing happens. So we saw early on that individuals weren't going to the hospitals, they weren't going to their physicians, they weren't going to the health department to get tested. But when we took the testing sites to a church parking lot, to a library parking lot, to a community organization or community center parking lot, they showed, they responded. So we took the testing to the people versus mandating that the people come to where the testing is being offered. That's number one. Number two is that it was very important for us to have a collaborative effort. So we have individuals like Dr. Alan Greiner, like Dr. Erin Corvo, we have individuals like the health department directors, we have faith leaders, we have pastors, we have community leaders, and we have residents, all a part of this task force. So all voices are at the table. It is very diverse. We have African American, we have Latinx, we have Asian, we have Caucasian, young, old. It is a very diverse group. And because of that, we have seen the successes that we have seen here in Wyandotte County.
That's great. Next question, Megan.
Yes, the question is, how can researchers and providers be trained on how to best engage and provide the best care for underserved populations?
You want to tackle that one, Dr. Chen?
I'm happy to start. I think that it starts with awareness. It starts with awareness that health equity is an important issue, the awareness that access is an important issue. And I think that after having that awareness, I think the important thing is not just to passively take care of patients who walk through the door and have access to having appointments, but rather to actively reach out to the community and really reach out so that we can develop more trust and reach out to look for opportunities to reduce disparities. And I think that's part of what we're trying to do here at KU. I think we are working with community leaders like Broderick. We have several advisory groups that help us better understand how we can reach broader and broader patient populations and where the issues are, and we listen to the community, and then from that we help educate our providers as well.
So along those lines, Broderick, could you tell us about the patient research advocacy program that you're a part of and how that may help boost diversity in clinical trials?
Absolutely. Thank you, Dr. Jensen. And actually, to a great degree, it's because of your support and your vision that we have the Pivot team, what's patient and investigative voices organizing together. And what Pivot is a group of survivors and co-survivors that come together and have conversations with researchers. So we now have the opportunity for researchers to come to our group to share their concept, to share their research question prior to developing their project. And so we can give them feedback as to what we believe will or won't work. For example, we have some great nurses within the cancer center, but 2 nurses going into a barbershop trying to get prostate testing done, great idea, but guess what? That's not going to work. But when we brought the barbers on board to say, hey, we want you to come alongside with us to do this, and guess what? It became very successful. So we can share information, we can share ideas, we can share what the community is looking for, we can share what patients are looking for in a way that they normally don't hear. So we'll be able to provide context, we can provide information to them to help them have a more successful clinical trial.
If I can add to that, I just wanted to really highlight the Pivot group that we have at KU, and also again through your support. The last question was about how we train providers, but we also have a new effort to train researchers in terms of collaborating with community members. And in fact, so we recently at KU received a grant from the National Cancer Institute to develop an educational program for our researchers so they better understand the importance of, when people do research, to collaborate with community members so they better understand what the issues are and how to then focus their research. I think it's a very exciting program that we're starting, and hopefully we'll be able to increase awareness in researchers as well.
Great. So we're close to the end of today's episode, and I want to talk about maybe some key takeaways that you would like to leave with our viewers, and we'll start off with you, Dr. Chen.
Well, I think the key takeaway is part of what a lot of people may not understand is our responsibility to take care of all patients in this catchment area, which includes all of Kansas and Western Missouri. So we really have a lot of effort to try to increase our services for patients in Central Kansas, Western Kansas, Southwest Kansas, with telehealth, with this series to educate. We also try to educate providers through the catchment area as well. We're providing clinical trials to the catchment area. This is really a huge part of our responsibility as an NCI designated cancer center, and all of these efforts help us reduce disparities related to cancer care access and outcomes, not only by race, but also by where somebody lives. So I think that's really the key take-home message. The other piece related to that is we actually need help in this effort. We need help from community members partnering with us. We have our community advisory group of members who volunteer their time they live from throughout the catchment area. They volunteer their time to advise us on what efforts we should focus on. So we need that kind of help. We also need help in terms of donations sometimes to try to increase and improve our efforts. We offer free cancer screening throughout our catchment area. We offer educational programs throughout the catchment area, and all those efforts we hope to be able to continue to increase over time as well.
Broderick, any key takeaways that you have?
Yes, sir. And again, thank you. two things that I will share from the KU Cancer Center Community Advisory Board perspective is one, we want to share and review the community's priorities and concerns, and then we want to identify and support the Cancer Center's efforts to engage, as Dr. Chen had mentioned, all populations within our catchment area. And so we want to make sure that all populations, every person, every patient that has the diagnosis of cancer has the same level of treatment for all individuals within our state.
Can't think of a better way to end our program. Just want to make sure we've covered all the questions, Megan?
Yes, we've covered all the questions for today.
Very good. So you're welcome to continue this conversation by submitting additional questions and comments, and we will monitor those throughout the day. And you can rewatch this and other Bench to Bedside videos on our website at kucancercenter.org/bench to bedside. Dr. Chen and Broderick and Megan, I want to thank all of you for being part of this week's episode of Bench to Bedside. That's it for today. Thank you.